thing. I'm going to get started. Remember last time, I know it's been a week since I've been back. We were going through the nutrition during pregnancy, and then you all had the workshop class on Monday, or I guess the practicum class on Monday. How'd it go? How do we feel about it? I was gonna say, I know we have Mikkel as our visitor today, but how did it feel like to actually put it all together, to like actually look at writing an ADIME nutrition care process?
It was a lot.
It was a lot, right? Kind of overwhelming. That's okay. That's very normal. When you're in your internship, that's like how it feels like for the first half, and you're like, I'm gonna be able to do this by myself, and you can. Yeah. So when you transition out of this class into 161B, we'll be doing a lot of ADIME notes, like at least one a week, if not two, depending on the disease state we're covering. So Monday was a good introduction to that. Hopefully you had fun with the case. All right, so we're going to be moving on in terms of content from nutrition during pregnancy to the nutrition during the lactation period or immediately postpartum. And then that's going to feed into the remainder of our talk today, which is actually nutrition during healthy peds. And a lot of times when we talk about pediatrics is the rapid amount of growth that takes place in that first year of life. We're going to be focusing a lot on like healthy infancy and then the tools that you would use for healthy early to late childhood as well as adolescence. Okay. And then not next week, but the following week, we'll then continue our PEDS discussion. We're going to be actually focusing on what we consider high-risk pediatric cases. So those children that you are more often than not going to see in the hospital, not always in the outpatient clinic setting, but sometimes if there are follow-up outpatient needs. All right, so let's talk about nutrition during lactation. So we're going to just do a quick review of the physiology of lactation. Now, have anyone been exposed to lactation, talked about physiology behind lactation? In any of your other classes? Didn't think so. So we'll do a brief review here. All right, so during pregnancy, if you remember from last week, we talked about how we have that different distribution of weight gain. And one of those areas was breast enlargement, especially because the woman is preparing to be able to lactate. Okay, so during pregnancy, you actually have the start of the physiology. You have breast enlargement, you get the development of milk-producing glands of the alveoli. Okay, so if you take a look at kind of what that looks like, here's the muscle of the chest wall. Here's where those actual milk ducts are. Okay, and the ducts as well as the little the cells. Okay, so during birth or after birth, what then helps to stimulate lactation is infant suckling. And then these two very key hormones, prolactin as well as oxytocin. So the two big hormones you need to take away for lactation is if you have prolactin on board, that's what actually helps produce the milk, and oxytocin is what releases the milk. So we have, if you have oxytocin, that's what we consider the hormone that helps with letdown, meaning the milk is being able to like flow through it into the baby. And what actually stimulates more milk production is the suckling or the removal of that milk. And we're going to talk about that in a couple different ways here, because that's really something that helps with determining how much milk a woman can produce and how often. Okay? So this is a feedback mechanism, right? So the more that you're feeding, the more that you have an infant that needs that milk that you're providing to them, the more milk a woman is going to produce, right? So it actually starts with the suckling of the nipple from the infant, and this is going to send messages via hair conduction to the hypothalamus. So it is also an endocrine process. Okay, and the hypothalamus is then going to send messages to the pituitary gland, which is where your prolactin is, and the pituitary gland, which is going to release the prolactin, which is then going to stimulate milk production, as well as oxytocin, which stimulates milk release. Okay, so when we're thinking about nutrient needs during pregnancy, so pregnancy and lactation are kind of like your two biggie with needing a lot of energy, right? So during pregnancy, we talked about we're basically growing another human. So during lactation, we're now producing a lot of food for this said new human. Okay, so it's quite an energy use. So we make sure that pregnant women are getting enough. However, similar to pregnancy, it's not like an astronomical amount of calories that a woman needs. We do need to make sure that we provide enough. So if you think about how much energy is expended per day, it's about 700 to 800 calories per day to produce the amount of milk that an infant would need pretty immediately after birth. And of course, depending on how long you breastfeed and the age of the mother and some other factors, that calorie range will change slightly, but for the most part, it's about 700 to 800 calories per day. So when we think about our pre-pregnancy additional calories, you need an additional, we separated up by 2 6-month period. So it's only an additional 330 calories for the first 6 months postpartum. So after the baby is born, about 400 calories extra on top of basic needs for the second 6 months. Okay. Remember though, if we again think about what was going on during pregnancy, was during this time the mother was increasing her fat stores. And a lot of those fat stores are what's helping to provide this extra amount of calorie needs. Okay, so we're mobilizing that fat as energy to be able to create the milk to provide for the infant. Okay. Protein needs are pretty much the same as pregnancy, about 25 grams or 1.1 grams per day or 1.1 grams per kilogram of pre-pregnancy weight. So again, in comparison, remember the RDA for just a normal adult is 0.8 grams per kilogram body weight. It's going up to about 1.1 grams per kilo. So not that big of an increase. If you do have a woman who did have to go undergo a C-section or cesarean section, you may need a little bit more protein just to help with aiding in wound healing. And then if they were out of a poor nutritional status going into pregnancy and throughout pregnancy, they may need additional protein to help with compensating for that. Other nutrients that you need to think about are omega-3s, particularly the longer chain DHA. Very similar to pregnancy, you want to make sure that you get enough to make sure that you're promoting proper brain growth, especially the first 3 months after birth. Okay, so who remembers the recommended amount of fish, of omega-3 rich fish to eat per week during pregnancy? 2 servings per week, right? About 8 to 12 ounces of the omega-3 rich, and which I guess toxic metal are we a little bit worried about that we have to make sure that our fish doesn't have to contain? Methylmercury, exactly, right? So same rules apply for when you're lactating. Okay, so normally women just need to make sure that they at least what I did during my pregnancy lactation was a good old-fashioned tuna fish sandwich one day and then a fish dish one other night. So but some people don't like fish, then you have to think about your other sources of omega-3 to counsel about. In terms of micronutrients, so you actually don't have as high a need for iron as well as folic acid, because remember, folic acid was really important with neural tube development. At this point, once the baby is born, the neural tube has been formed and the baby is out. And for iron, you don't have that increase in blood volume where you do need that higher iron rates. So we're going to talk about iron and where it's important for the infant, because during the first at least 4 to 6 months of life, if you have a mother who is nutritionally adequate, you may not necessarily need extra iron for the infant because the infant themselves may have enough stores. You may need to increase your micronutrients for other nutrients though, because that's what's going to be going to the milk for the baby. Okay. Vitamin D is actually one of our micronutrients that the milk content really is dependent on the mother's diet, and oftentimes it is suboptimal for what the infant needs, and so there is a recommendation for supplementing vitamin D in infancy, and again, we'll talk about that later on in the lecture. Oh, and also wanted to point out another reason for a less need for iron, say with pregnancy, is that a woman is not menstruating, so you don't have those additional losses that you need to replace that you would in regular adulthood. Yes, question?
What did you say about the calorie again? What's the difference between the first one and the second?
Oh, why you would need a little extra during the second 6 months, or just between the 700 to 800 and this one?
Yeah, but when do you need 7 to 800?
Oh, so in per day to support creating that much milk to provide, it's a big energy cost. So it takes actually 700 to 800 calories per day to do that. So even though we're only recommended to only have a little over 300, a little over 400, depending on how many months postpartum, you have all those extra fat stores that were starting to accumulate during pregnancy, and because of those, we're mobilizing that in our bodies, if you're a female and you're lactating, to be able to cover the other rest of that cost. Great question. All right, so this just kind of puts together, if you think about the nutrient need increases for somebody who is lactating. So this is the percent increase over a non-pregnant, non-lactating woman. So just, you don't need to necessarily memorize this. The only thing that I just wanted to kind of show is that there are minerals that really don't increase at all. And we're gonna talk about calcium in the next slide, but there are some that do. And then there are some that there's a question of whether or not iron needs don't really increase, but there is a question of whether or not if you have a woman who is already suboptimally anemic, that they need to cover the cost of they need to increase their iron needs, and if they want to provide a little extra more in their milk, should they also be increasing their supplement or increasing their intake. All right, so let's talk about calcium, lactation, and bone loss. So women lose a lot of calcium not only during pregnancy but also during lactation. Right, so if you're thinking about that to support lactation, it's about 400 milligrams of calcium a day, up to 1 gram per day with twins. So if we think about this in terms of food, so for all of our milk drinkers out there, every 8-ounce glass of milk is 300 milligrams of calcium. So if you're a woman who is lactating, you could be losing over a glass of milk per day, basically, of calcium intake, right? And it is really this demand is really met by increased mobilization of calcium from the skeleton. So our bodies become very efficient, like I talked about in pregnancy, in mobilizing as well as absorbing calcium from food during these two different physiological statuses for life, if you're a female. Okay. Really, this mineral loss is due to hormonal action, particularly from parathyroid hormone, released from the breast tissue, as well as a lower estrogen content. So that just starts to make you think about, like, when we move into maybe the adulthood and aging life cycle form, that if you have somebody who has low estrogen, meaning maybe a woman that's going through menopause, when we start to lose estrogen, that they too may be having mineral loss going on in their bones. And that's why a lot of times if you've ever seen a commercial with like Sally Field or these older actresses, like one of Paltrow's mom, like Danner, about taking their calcium or their osteoporosis medications to help with the fact that they have bone loss during this time in their life. Right? The really cool thing about women, though, is that if you are pregnant or lactating, you actually don't see higher rates of osteoporosis because the mineral is really fully restored within a few months of weaning. So even though you are actually like actively taking out this calcium to support pregnancy, to support lactation, once a woman has weaned her child and is not actively breastfeeding anymore, the mineral levels actually restore, which is pretty cool. Okay, so you don't actually see long-term deficits in your skeleton mineral content. And what that means is that if you actually did a bone scan to kind of see the density of your bones, you wouldn't see that somebody who was lactating and pregnant had lower bone mineral density versus somebody who never lactated or was pregnant if you compare to something else. All right, so for breastfeeding, what are the recommendations? Well, the Academy of Nutrition and Dietetics, as well as the American Academy of Pediatrics, recommends exclusive breastfeeding for the first 6 months of life. So this means nothing else, no other introduction of foods, no other introduction of beverages like water. Be really just trying to breastfeed exclusively for 6 months of life. And then breastfeeding in addition to complementary foods. So when you start to wean, meaning you're introducing other foods and not only exclusively breastfeeding for up to 12 months. Okay. So depending on where you go, this is the recommendation. More often than not, you see the introduction of foods kind of starting around 4 to 6 months. And it is infant and family dependent, but the recommendation really is for the first 6 months of life. There was this set of studies that just came out. It's a nationwide cross-sectional observational study. So if you remember, cross-sectional studies are one point in time where they, in this particular study, they were collecting 24 dietary recalls from caregivers of infants and toddlers. And they were looking from birth through 4 years of age. It's called the Feeding Infant and Toddler Study, and it's been going on since 2002. Anyways, this is the third release of data, and they had some interesting numbers about women who initiated breastfeeding, as well as how long they were breastfeeding. And overall, since the last release of data in 2008 in the U.S., more women are introducing breastfeeding, and they are breastfeeding for a little bit longer. So they're getting closer to those Healthy People 2020 goals of increasing breastfeeding initiation rates as well as duration rates. So we're slowly moving there. In terms of introducing complementary foods, it's a little mixed, but we'll talk about that more in the PEDS lecture. All right, so why do we breastfeed? Breastfeeding is amazing. It's great. It helps with multiple things, including allergic reactions to human milk are very rare. right? So if you introduce formula, it doesn't necessarily mean your infant is going to have allergies, but there is higher incidence of allergies because the proteins in human milk are basically suitable for infants. Mother-infant bonding is key. There's a whole initiative once your baby is born to do immediate skin-to-skin contact. You get actually this release of hormones, especially like the pheromones, and you get like nice and cozy and like sleepy. It took me like 2 weeks to realize that like after I had my son, anytime he was laying on me, I was like, I'm just so tired. And I realized, oh, hormones, they're pretty strong. It does really help with bonding. It also helps you with being able to kind of cue into your baby and your child a lot more and a lot quicker to really know like, oh, that cry really means that they're hungry versus that cry means that they have gas or that they're unhappy. And so it does really help with starting to, get in tune with what the baby needs, particularly around feeding, which is very difficult at first because, I don't know if anybody in here has kids besides Mikkel, but when they start crying, you're like, I don't know what you want and you can't tell me. So anyways, breast milk is also much higher in bioavailability, so meaning infants are able to actually take in more of the nutrients that are coming from human milk. Okay, easily digestible form. It is nutritionally balanced. It is it is basically created to meet the needs of your developing infant. Helps with decreasing infant morbidity. So those that are breastfed have lower risk of sudden infant death syndrome. Has anybody heard of that before? Or SIDS? And so there's a couple, they have different thoughts about that because you're like, well, how does breastfeeding and breast milk and content actually help with reducing SIDS? Some of it is, it may be nutritionally. A lot of it is also thinking about environment. If you have somebody who is consistently breastfeeding their baby, they're a lot more in tune to hearing their crying and being able to check in on them and such like that. So there's, external versus internal benefits as well. There's maternal health benefits. So there's been a lot of work taking a look at type 2, chronic diseases later in life, but particularly type 2 diabetes risk for women who are lactating. And there was a couple of papers that just came out taking a look at, it's the Procardia study that has been done in the US, and they were looking at how the longer a woman is lactating and breastfeeding her infant, the lower the risk for acquiring type 2 diabetes later in life. And these were healthy individuals before, so this is aside from individuals that had gestational diabetes or had type 1 or type 2 diabetes prior to pregnancy. Okay, a lot of the mechanisms behind that are still being a little worked out, but one of them is that prolactin in general can help. They think is one of the hormones involved with helping with decreasing your insulin or increasing your insulin sensitivity. So it's still being worked out, but there is definitely some more maternal health benefits with initiation and duration of breastfeeding. It's been shown to help with reducing obesity. It is a bit of a common myth to say that if you breastfeed, you're going to automatically lose all your, pregnancy weight, but it does help. It is an energy, cost, but it does help with reducing obesity and helping with, getting you back to your normal weight or pre-pregnancy weight. You also see improved cognitive health, neurological development in your infant, and reduced incidence of childhood asthma as well. So lots and lots of benefits. Now, with that being said, breastfeeding's not for everyone, and sometimes it doesn't work out, and that's okay. And we're going to talk about why we have formulas, and that's fine. And there's a big movement that we should not be shaming anybody that can't breastfeed or has tried to breastfeed and it just hasn't worked out, because there's a lot of obstacles. And I'll be honest, when I had Adam and being from nutrition, I study nutrition during pregnancy and lactation, I'm like, it's gonna be easy. Of course I'm gonna breastfeed. Of course I'm gonna be able to do it, like no problem. It's the hardest freaking thing of my life. And there's so many things that even though what you're supposed to do, it's not easy and it's not intuitive. And as a healthcare provider now, I help out with some of the lactation consultants or consults that come into the hospital, and there's a lot of barriers, and I really try to work with those moms to be like, dude, I've been there now, and now I really know what it's like, and I can actually provide feedback on it. Because of course before I was like, oh yeah, you just need to pump more. Pumping sucks. I don't know myself if you had to pump, but pumping sucks. Yeah, you did have twins, so never mind. Yes. It's not comfortable, and when we talk about being able to have a baby-friendly workplace or baby-friendly hospital environment, that's being able to set up an environment that is supportive of breastfeeding. And what some workplace definitions of that are very different. I was very lucky. I obviously had my own office here on campus. The daycare where Adam goes on campus, there's 3 moms in the room. There was like a nice like couple of rocking chairs that we could all use. Very supportive of being able to breastfeed. At the hospital, luckily our office is one of the designated lactation sites. Super easy, but I still had challenges. Think about other people that, you know, maybe come in and their employer's like, well, we have this back closet. And that sounds like that's a random thing to say, like, why would you just, you know, save a back closet for somebody to pump? That's a reality. Like, I've had friends that have told me that they've gone to conferences and such because they're lawyers and they were told, like, well, you could pump in the bathroom. And, like, it's like, you're, like, sitting there pumping and you're exposed. It takes a lot of support to be able to successfully breastfeed, especially if you do have issues with latch and your baby doesn't latch on, or engorgement, and then it's painful and such. So anyways, as dietitians going into this field, or even as other healthcare professionals that might be working with this population, this is an area that definitely still needs a lot of work. Even though we know the science, there's a lot of the environmental obstacles and stuff to also work on. But like I said, with that being said, it doesn't necessarily mean that breastfeeding is for everyone. We just want a baby who's fed and healthy. So we're going to talk about the nutritional value of milk, and then we're going to talk about where formula fits in and how that kind of compares to breast milk, because formula is regulated, and the manufacturers do try to meet all of the needs of what breast milk can provide as close as possible. Right, so when we're looking at the breakdown of breast milk, if you think about whey to casein ratio, so this is going to help with digestibility. I always think about it this way. Who remembers that nursery rhyme, Little Miss Muffet, who sat on her tuffet eating her curds and whey? All right, so the curd is the hard, kind of tough protein that's a little bit harder to digest, right? If you think about a baby who's brand new, like their little digestive system is just starting to work out, so we have to make sure that we can give them enough of a protein that they can digest. And so that's why breast milk is actually 90%, or if you think about 90-20% whey. Okay, so more whey, that's the kind of like liquidy part. If anybody eats cottage cheese, I also think about it that way. Curds and like the liquidy part in the cottage cheese, that's the whey protein part. Okay, so when you're lactating, there's 3 different like types of milk as you like mature, I guess, through the first year of life. The first milk that comes in is called colostrum. And then there's a second milk that comes in, that's your early milk, and then there's like it's not called advanced milk, but it's called mature milk, that's what it is. And when you start out with your first like early milk, not the colostrum, your whey to casein ratio is more 90-10 versus when you get to your more mature milk, which is like 6 to 7 months postpartum, it's more of an 80-20. When you take a look at formula, it's pretty difficult to get it down to what breast milk is. Typically, it's more like a 20-80-ish, depending on average 18 to 82. So already, like the digestibility of formula is a little bit more difficult for infants. If formula is introduced a little later on, if you think about as the digestive system is starting to develop a little bit more robustly, then they can kind of tolerate it. But there are some babies that do have a really hard time when formula is introduced really early on. The type of fat really reflects the maternal diet. So this is why it's important to make sure you're getting in your essential fatty acids. There are also 2 different types of milk when it comes in. There's fore milk and hind milk. So the fore milk that like first comes out is lower in fat and is higher in carbohydrates like lactose. And then the hind milk is a little bit more rich in your fat. That's the same as you get into the more mature milk, that has more of a higher fat content versus your early milk that comes in. So as you get more later in postpartum, you have more fat content in your milk. For your vitamins and minerals, your vitamin D, again, is going to really reflect what the mother's levels are. Many mothers are deficient, so that's why the recommendation is 400 IUs for 0 to 12 months. And so that's why most exclusively breastfed babies get vitamin D drops, or they can get the little syringe of the D-Visol. Go with the vitamin D drops. The syringe is very difficult to get an infant to take, yes.
If the mother has like a high saturated diet, would that reflect also in the milk?
Yes, yeah. It will, that's a good question. If you have a baby who's formula fed, vitamin D and most of the micronutrients are not normally an issue because they're fortified back in. Breast milk is inadequate in iron, and so that's why I mentioned why it's kind of interesting for the iron requirement in lactation is because the babies usually have enough stores to get through that first 4 to 6 months of life. However, if you had a mom that was previously iron deficient, or a baby that was delivered preterm, you may have a higher need that you, for the mom to help get a little bit more into the breast milk. It's usually individual specific. But if you have a healthy term infant, typically you don't need to think about iron until 4 to 6 months. Okay, so the fatty acids that are found in breast milk, primarily your polyunsaturated fatty acids like your linoleic and your linolenic. You do have some, intrinsic trans fatty acids, as well as your conjugated linoleic fatty acids. And again, this is really affected by the maternal stores and the maternal diet. Okay, and if you also have a mother who is restricting energy, and they have to get their energy stores from a different, or their energy source from a different fuel. And importance reflects the significance of fatty acids for the infants is that really you need to make sure that they're getting their essential fatty acids because it does really help out with neurodevelopment. And I know there are some studies taking a look at if mothers are supplementing versus eating food and how much that's reflected in the breast milk, and it's still a little mixed. You can also see improvements in something called atopic dermatitis, which is a skin allergy. It helps with immunity and immune function development as well as visual development. So a lot of these things like the visual development, neurodevelopment, immunity is something that also takes place during pregnancy. It's really the skin conditions that you start to see more of like a post-birth. All right, so if we're doing kind of a compare-contrast of formula, both are similar in energy, which is about 20 calories per ounce. Similac, or the Abbott formula brand, they did a lot of studies taking a look at breast milk content, and they felt that it was closer to 19 calories per ounce. So now all of their formulas are 19 calories per ounce, but 20 calories per ounce is fine to use. Cow's milk contains more protein, especially casein, and cow's milk is the base for formula, right? So formula is going to be made from a cow milk base, so that's why you have more casein versus whey. Okay, it's going to have more vitamin D because it can be added in, more calcium, as well as more phosphorus. The cow's milk is also going to be lower, though, in your linoleic acid, your vitamin E, and then the whey protein. And we're going to talk about the form of protein that is in breast milk. It's in this form called lactoalbumin, which is why it's so easily digestible and highly bioavailable. Human milk also contains arachidonic and acid, as well as the DHA. All out. And there is higher amounts of the 2 amino acids, cysteine and taurine, especially because there's a higher need during infancy for that. Okay. So again, this just kind of reviews that casein in cow's milk is going to be that hard to digest curd, whereas the lactoalbumin, which is a whey form of protein, is that soft, easy to digest curd. Okay. So this just kind of like gives you the breakdown of like the big macronutrients and micronutrients, and kind of highlighting where like the two, the bigger differences are. Again, protein is kind of your main one, so more whey to casein in human milk, more casein to whey in formula. And then some of where you see the micronutrient contents. The other thing that comes up is osmolality. So it's a little less osmolar in the breast milk versus cow's milk, which can come up especially if you have babies that are a little sensitive. And so you might, and that really comes down to how much is actually in the formula. So if you think about osmolality as like a function of concentration. And then also if you're thinking about that you're adding in more, usually there's a lot of more protein that's a little bit more acidic, so that can also, shift things in the osmolality calculation a bit more. The other big one is the calcium. There's a ton of calcium and phosphorus in formula compared to human milk, which is interesting because if it doesn't actually need any extra calcium. Or that should say it doesn't need extra calcium, because it needs that much calcium. That is like, let's see, for adults the recommendation is 1,000 milligrams per day if you are 19 and over, so that is almost 1,200 milligrams per liter consumed. That can be quite a lot. Okay. All right. So other benefits of breastfeeding. So breastfeeding and anti-infective factors. So both human milk and colostrum. So again, that's that first amount of milk that comes out, the first like 4 or 5 days after birth. And that's a thing that I remembered, but that didn't remember when I had Adam, was that Colostrum is like, it looks like you're barely feeding your baby, but really you are. It's this kind of yellowish looking milk that only comes out a little bit, but it's really rich in these antibodies and anti-infective factors that are not present in infant formulas, and it really helps with starting to stimulate immune function and helping to build upon that immune system that's still being developed postpartum. Okay. You get the secretory immunoglobulin A, which is the predominant immunoglobulin in human milk. It has a role in protecting the infant's immature gut from infection. We don't want like colonization of bacteria in babies' immature guts, especially because when we talk about some of the physiology that's taking place in infants, we'll talk more about why these factors are very important in helping to maintain immune function. Lactoferrin in human milk is the iron-binding protein that deprives bacteria of iron, therefore slowing growth down. Lysozymes, so those are the bacteriolytic enzymes that are found in human milk that actually destroy cell membranes, and bacteria after peroxides and ascorbic acid have inactivated them, so they're working together again with other nutrient factors. And then human milk also helps to enhance the growth of lactobacillus bifidus, which helps to produce an acidic GI environment that interferes with the growth of certain pathogenic organisms. So helps with maintaining a healthy gut microflora. And there's a lot of very interesting studies coming out taking a look at the gut microbiome and breastfed versus formula-fed babies. Also those that were born to a mother regular vaginal birth versus those that are born cesarean. So there's a lot of interesting research taking a look at that and what that means in terms of long-term health outcomes. All right, any questions before we talk about some factors that would affect milk composition? We kind of went through a lot about breastfeeding and such. Okay, all right. So we're going to talk about a few items that can affect milk composition. So that's really going to be focusing on what is in the milk, not necessarily the volume of milk. So well, I guess we'll go through most all of these. So thinking about maternal age, especially because if you take a look at most women today, especially those that are pursuing higher education or pursuing a career, a lot of women are having their children later in life. So you have to start thinking about maternal age. So we talked about a little bit last week about, when you're a little bit older, there are other complications that could be associated with pregnancy outcomes. So in general, when you think about that in terms of lactation success and the composition of the milk, in general, you don't really find, just when you're going through the literature, any association between maternal age and milk composition. So it doesn't really matter if you're young versus old. You see in adolescents particularly, so remember that was one of our special considerations in pregnancy, so kind of following through, adolescents do produce a little less milk than adults. So if you're a regular adult age from early 20s on up, you don't really see any associations, but adolescents will produce less, and you also see that they have poorer lactational performance, meaning they have a hard time with, maybe babies being able to latch on and produce enough milk, or being able to get them on both sides. And so what happens is they discontinue lactation sooner than somebody else. You also see higher sodium and lower calcium magnesium in adolescents, and a lot of times this really directs more with their diet intake. So again, thinking about what adolescents are eating. If you remember from last week, we talked about really targeting adolescents and figuring out what they're eating to make sure that they get enough, since unfortunately more often than not, adolescent intake is not optimal, not only for regular day-to-day, but definitely not for pregnancy. There hasn't been any association between parity in milk composition. So if you have multiple births, multiple births, unless you have more than 8 children. Okay, and then you might see a little, your milk quality might decrease a little bit more, and that's mainly because of maternal malnutrition in the mother's stores. And this is also if you have multiple children close together, so the mom doesn't even have a chance to recover and restore all of her nutrient stores. Delivery and stress. So women that have a short labor, so without any peripartum complications, usually have earlier milk production and milk protein synthesis with larger volumes. I can attest to this. I had a very short labor, and I met with a lactation consultant right away, and she said, be prepared, your milk is probably going to come in within like 3 to 4 days versus 4 to 5 days, and it's going to come in quite a large amount. And I was like, I didn't think that I had quite the stores to do that. And so she automatically had me get a hospital grade pump, which pumps are like a whole other separate conversation, but a hospital grade pump is a lot more efficient at being able to remove excess milk or to produce more milk. And thank goodness that she did, because it was very true. Actually, my milk came in so much that it was very uncomfortable, and I was engorged and had to do extra pumping and a lot of extra like ice packing and such like that. So that can happen. Women with long or stressful labors may have higher stress hormone concentrations in their breast milk. In terms of what that means for the baby, there isn't quite that, there's not a lot of, finite research about that. Basically, you can just detect it in the milk. There hasn't really been any full studies that have shown that these women have, kids that, then have, adverse reactions or non-adverse reactions. Maternal and fetal stress is associated with delayed lactation and casein milk protein appearance. So meaning that milk comes in a little bit later. There might be, some difficulty with the transfer of like full milk into the baby, and then you see more of the whey versus the casein. And then women who have a C-section exhibit intermediate effects, meaning if it was a very non-traumatic experience C-section, some of them are fine, meaning their milk comes in normal. They don't have issues with lactation or any of the nutrients in there. Some, if it's traumatic or not traumatic, some of them, may have some issues with lactation. It kind of also depends on the woman as well and the support that they have. Energy restrictions. So malnourished women actually produce milk of adequate volume and energy content, which would seem counterintuitive, but evolutionarily it appears that women who are having babies, that's what we were made to do, was to be able to create life and be able to sustain it. So our body actually prioritizes making enough milk by taking from the maternal stores to make sure that, or taking from the external maternal stores as well as the external diet to be able to produce enough milk to continue to support the baby. Women who diet and or exercise acute or long-term during lactation generally produce milk of adequate volume and energy content. There's not also really any effects on minerals or immunocomponents. Later on in lactation, if you have a mom who is breastfeeding and they're at 6+ months, there are some reports that milk volume, if you are a heavy exerciser, may go down a tiny bit, but also that could be coinciding in the fact that the baby is starting to introduce more solid food. So in general, the demand for breast milk might be overall lower. So they're still trying to figure that out. I exercised and breastfed Adam for the first year of life, and definitely around 8 or 9 months, I felt like my milk volume was going down. I don't know if it was a combination of both or just he was starting to eat more because he loves his food. All right, obesity and lactation. So maternal obesity in general is associated with low rates of initiation, meaning those women who are obese don't necessarily initiate breastfeeding, or the duration of how long they breastfeed is a little bit lower. And there are many possible reasons for that, not necessarily from a physiological obesity sense. It could be an environmental sense as well. You see poor infant feeding behaviors as well as reduced hormonal responses for those that are obese and lactating, which is probably what feeds into why initiation duration is decreased in these individuals. All right, so maternal nutrition and milk volume is protected unless you have somebody who is extremely malnourished or underweight. That's when you start to see the milk volume start to decrease some. Your main predictor or influence of milk volume, though, really is the number of feeds per day and the demand for breast milk by babies. So if you have a baby that is feeding every few hours, you're going to have a mom that's producing quite a bit of milk to support that need. If you have a baby that, let's say they get sick and they're not able to eat that often, or they're having trouble with breastfeeding, the milk volume, because the baby's not stimulating that or being able to clear that milk, will go down. It's actually a very challenging, frustrating rewarding but very challenging situation to make sure that you are having the baby eat enough or you pump enough to be able to support continued volume. So if you start to think about when women transition to go back to work, especially if they're not going to be around their babies all day long to be able to feed them, they have to be able to pump up and pump out enough milk to be able to kind of stimulate or the same times that they would be feeding their baby to make sure that milk volume stays up. So again, if you have a baby that's feeding every 3 to 4 hours and you think about an 8-hour workday, that can be anywhere from 2 to 3 feedings in the day. So that's breaking up your workday to be able to go pump enough and store it to be able to bring back to feed to baby so that you can keep your milk supply up to support that. Okay. So it's really not the volume, it's the composition of milk that's more affected by maternal nutrition status, particularly fatty acids, water, except for, and within the fatty acids, water, except for, and then, water-soluble vitamins. I don't know why water got cut off there. Except for folic acid and your fat-soluble vitamins plus iodine and selenium are going to be your most directly affected. Question, Katie.
So you talked about the amount that you're eating birthdays per day. Is that included at night? Okay, so it's I know
Yeah.
babies eat at night. But
Yeah, no, it does definitely mean at night, and that's why there are some moms, especially if you have babies that we like to say are amazing and sleep through the night. But during the day they're feeding quite often. You might have some moms that actually have to get up and pump because they are very uncomfortable and full, or let's say during the day in their schedule there's a time where they just won't be able to feed the baby because they're at work or they're not able to pump. They might need that extra pump session to be able to provide enough milk. So
if
like
you were to wake up in the middle of the night to pump, you'll probably produce more milk. Or keep producing more milk.
yeah, if you were pumping, yeah, I mean you'll produce the amount that your baby's eating during the day or that you need. Some people get up and pump early to have enough extra on hand. So Adam used to go, he's been going to bed at 7 for a long time, but I would wait and pump at 10 p.m. before I went to bed. And then he would sleep until 5 a.m. and then I would feed him. And then he would sleep until 7:30 and then I would feed him again right there. So I usually had to do an extra pump session at night because getting from 10 to 5 was a long stretch. And then also there were some times that I would get up to pump an extra amount just so I had enough for him during the day if I knew it was going to be a long day that I couldn't be with him, and also just to you try to have an extra stock on hand because you can freeze it. So Sophia.
Does the number of feeds per day also only depend on the demand for the baby?
It does, and we're going to talk about that in the PEDS lecture. Yes, especially as we think about physiology and how much a baby can actually take in at one time. They're going to feed more often early on and then increase that out. Great question. Okay, so what about intake of non-nutrients, right? So milk can be a vehicle for not only nutrients but also toxins as well, right? So any drugs, metabolites, viruses, nicotine, caffeine, any of all those things. So we think about last time, all of those different items that you have to avoid or limit during pregnancy. Some of them you don't have as much of a transfer during lactation, but there are still some that you do. One that comes up a lot is alcohol and your pain meds like Tylenol. Acetaminophen is Tylenol, ibuprofen is Advil, and cat feed. They are compatible with breastfeeding, meaning you should probably you can consume them safely. However, they still get into the milk, and really you should be using them for as short a duration as possible. And more often than not, in your primary care visits, they say you shouldn't be using them at all, especially early on, and that perhaps maybe there's this thing called pump and dump. So basically, if you consumed those items and then you had a pump session afterwards, not immediately afterwards, but within an hour afterwards, when you would have that transfer into your milk, and then you dump that pumped out milk, and then the next feeding would be, without any of those potential toxins. Okay, so it is something to think about in terms of what you're putting into your body. Viruses are a big one, because if you think about viruses like HIV or human immunodeficiency virus, you actually have to have these moms not breastfeed because they can pass the virus into their babies from that route. Women who smoke They have a lower milk volume. There's really little effect on nutrient concentration though. So overall, if you smoke, you're not going to provide. That's the one thing that would lower your milk volume from something that you'd be ingesting. All right. So just to oh, did you have a question, Katie?
So you said nicotine's transferred in breast milk. Can you still breastfeed if you're smoking?
Okay. You can still breastfeed if you're smoking. It's not recommended. It just you will typically have lower milk volume.
But the baby will still get nicotine, right?
Yes.
Is it significant? Like a significant amount?
I have to go back to some of the toxicity studies for that. I think you'd have to define significant amount because you take a look at like what is nicotine interfering on. Like, are you actually seeing like developmental like cognitive decline? And so you're not going to be able to see that until like maybe around 2 years of age. I think some of the studies show. And then it also depends on like the frequency and duration that they're smoking and like the type of cigarette or, I mean, nowadays the like e-cigs, like the if you're vaping. So it's hard to say what like that limit is, but I also think, yeah, no, you don't. You obviously you can. If anybody's ever watched Mad Men, like everybody in that era smoked, drank for pregnancy as well as lactation, but it's not recommended.
Don't you think that the baby would be like more predisposed to have a nicotine addiction?
There is some interesting research coming out about that. Yes.
Would a nicotine patch do the same thing?
I don't know about that one. I haven't thought about that one. I don't know. I would have to see if because the patch is being like absorbed dermally, like how much is being transferred and uptake through the breast milk. And if it's the same as when it's being inhaled, I would have to look into that. I don't know about that one. I'm sure, like, I'd have to look. You could probably look at the black box like warning on nicotine patches, and I'm sure there's something that says like would advise against using this if you're pregnant or breastfeeding, knowing that you can have some nicotine transfer into the breast milk. But I don't know if there's any studies that have like actually looked at that. But I can look into that if you're interested. Yeah.
And then just one more quick question.
Yeah.
For the second bullet.
Yeah.
All of those values, I assume like when you're breastfeeding, you have an upper limit. Like your dietitian will tell you like you can only have this much coffee or this many drinks before you like pump a dunk or beats.
Yeah. I mean, so this is. I asked this because obviously I'm an avid coffee drinker. And I mean, my doctor said, try to keep consistent with what you did with pregnancy. As the baby gets older, like, maybe you can increase more, or like if you really needed to take like ibuprofen, only take the recommended dose once, and then that would be it. And maybe try to like, stagger your feeding so that you're not feeding them like very soon after, but maybe later on once the drug has metabolized and kind of processed through your body a little bit more. But there's no like 100% like strict recommendations. It's just more like you should try to omit if possible. Like I can't. When I guess started consuming an alcoholic beverage again, it was after like Adam was 6 months, and then it was usually after he went to bed, and so then I had a few hours before I pumped, or if I pumped and dumped, or I pumped, didn't pump, and then just waited until his morning feed to feed him, knowing that it would have been out of my system by then. I mean, some people say like, oh, if you can feel the effects of alcohol, which is very different per person, then that means that's when it's in your breast milk, which I think is just more of an old wives' tale. But it's also really hard because they're just now really starting to like kind of characterize the composition of breast milk a lot more. And since it's so individual how people like digest and absorb things, particularly alcohol, it's kind of hard to have like a, like if you drink this amount, you'll have this amount in your breast milk. So you need to wait this amount of hours. So that's why I was gonna say the recommendations are a little like, I don't want to say wishy-washy, but they're just like, it's not as clear-cut as like, if you introduce alcohol during pregnancy at any time, there is a risk for getting fetal alcohol syndrome disorders. So.
Well, and with like medications like insulin and ibuprofen, it would really depend on like how well you metabolize it and how much breast milk your baby's actually drinking. Because if they drink like 2 ounces or 4 ounces.
Right. Exactly. Yeah. Exactly. So it's a little bit open. So similar to to pregnancy, there's like a nice little like summary of nutritional care in your textbook. So again, like including a variety of foods, focusing on nutrient dense, energy intake to allow for maintaining health and well-being, trying to keep a calorie level no less than 1,800 calories per day on average. Obviously, each individual is going to be very different, but typically you shouldn't be going less than that. Protein intake to meet needs, making sure you get your fatty fish in, making sure you get enough vitamin mineral intake. Drink to thirst. That is the other thing that comes up with lactation that I feel like a lot of people don't talk about, is that you are also like losing a lot of fluid through breast milk, and so a lot of women are very dehydrated, and I didn't realize how dehydrated I would be, and like literally had to have like a giant thing of water out anytime I was feeding because I was so thirsty all day long. So yeah, here's the wishy-washy. If desired, alcohol beverages can be consumed on occasion in moderation. Not recommended with preterm, very young, or sick infants. So that's why they say to really wait a few months. Try not to include any toxin and non-nutrient substances from food, water, environment as possible. So yeah. So any questions? Because then we're gonna move into healthy peds. Yeah, Jacqueline.
On the 2 slides ago,
Yes.
you said like women who smoke have lower volume. Is
Yes.
that including women who have previously smoked, or just women that are smoking during?
Oh, that is a good question. I would have to review those studies. I think it's for anybody who is smoking during lactation. There wasn't really a definition between if they were previous smokers versus new smokers. I think it's just anybody who is smoking during lactation. Yes.
Should we also incorporate the formula into breastfeeding? Because since the formula has higher calcium or other.
Yeah, that's a great question. You don't need to. If you have an infant that is exclusively breastfed, they actually grow as well, if not sometimes better, than those that are formula fed, and that's looking at like long-term growth, not just during the short like first year of life. Some individuals may need the extra from formula because they're not producing enough volume of milk to be able to meet those needs, and that's very common as well. And a lot of times we have families that have to go home and they mix their breast milk in with their formulas. And if you have a baby that is not growing as well, that's actually something we fortify the breast milk first, especially if mom is continuing to pump out with formula to increase the calorie content. So if you start introducing formula, there is the chance though that the baby may not, accept as much breast milk, or your supply goes down. Like if you have to do more formula versus breast milk, and so you're just thinking about all of those things as well in terms of thinking about if you want to continue to try to breastfeed as most as possible. But you can definitely introduce formula, and that's fine and very accepted and happens quite often. As a peds dietitian, I feel like you do a lot of formula mixing with families with failure to thrive kids, which we'll talk about next week. No, 2 weeks. So. All right, so it is 9:03. If we can come back in like 5-ish minutes, I know we have a lot to go through for peds and child. So of course there's going to be a ton of Adam pictures. I mean, Mikkel left already. She's not going to get to see them all. But I do have to say, everybody always says, I should say all of Lenny's family said at first that Adam looked exactly like Lenny, but I think this little guy looks exactly like this rockin' 80s girl right here, right? Look how similar we look like. And right here, yeah. Anyways, no, Adam is definitely like a very half and half combo of Lenny and I. He's me from the nose and ears up, and he's Lenny from like the mouth down. But anyways, so this is obviously Adam, and this is me. This is me watching the Olympics. I was really into it in my bathtub there. Anyways. Okay, so some terminology we're going to cover first when we start thinking about peds, especially the infant peds. And some of these terms we talked a little bit about last week, but some of them are going to be new terms as well, especially when we start tracking growth and tracking growth and using the growth charts. Okay, so gestational age. So this is the age of an infant at birth, okay? This is determined by the length of pregnancy, and it's usually determined by number of weeks since the last menstrual period. So when you are pregnant, the first thing like your doctor asks is like, when was the date of your last menstrual period, like day 1, and that's when they technically start the pregnancy clock or the gestational clock. So when you say what is the perinatal period, that is, if you think about that chart that I posted up last week, that is from 28 weeks of gestation through 4 weeks after birth. So this is our second-ish trimester through the very first month of life. The neonatal period is that first 28 days of life. So remember, that's when like your neural tube is closing, and if you were to have a spontaneous abortion, that's when that would take place. If you have a term infant, that means that you have an infant that's born between 37 weeks and 42 weeks of gestation. It's very rare that you have doctors let women go past 42 weeks, right? So once you get to 37 weeks, you're considered term. If you have somebody that has a baby before 37 weeks, you have premature or a preterm infant, okay? And then there's actually this growing body of literature taking a look at the preterm infants. They call them early preterm and late preterm. You don't necessarily need to know that, but it is kind of interesting to see that these babies that are born 34 to 36 weeks gestation actually are uniquely different than those babies that are born before 34 weeks gestation. And so if you go into peds and you go into neonatology, that's where that kind of comes up more, but it does change their nutritional needs as well as their medical outcomes. Okay. When we were talking about birth weight, right? So I know we talked about low birth weight, IUGR last week, a little bit more, so we're gonna just review those. So if you have a baby that's born have low birth weight, that means that they're less than 2,500 grams. Very low birth weight, less than 1,500 grams. Extremely low birth weight is less than 1,000 grams. And then we get these gestational age terms. So appropriate for gestational age would be somebody who was born, you know, they take a look at the age at which they were born, okay? And then if they fall within the 10th and 90th percentiles using the intrauterine growth grid, which is the growth chart, they're considered appropriate for gestational age, okay? If you have a baby, taking a look at their gestational age, again, we're comparing, if it's lower than the 10th percentile of the standard weight for gestational age, they're considered small. If they are above the 90th percentile, then they're considered large for gestational age. Okay. So differences between low birth weight and small for gestational age. So low birth weight may be due to a short-ended period of gestation. Maybe they were born premature, okay? Or maybe they had to, you know, something happened medically and they had to be delivered early. So yes, they were premature, but it just was abruptly ended. They weren't on track to be premature. If they had experienced IUGR, restricted intrauterine growth as well, okay? So remember, we talked about a lot of different ways of why somebody might have a low birth weight. So even though they may have been born at term, you can still have a low birth weight. Okay, small for gestational age infants whose length and head growth are normal on the growth curve has experienced something called intrauterine or asymmetrical intrauterine growth restriction. So basically, their head circumference and their length is normal, but their weight is low. That's considered asymmetrical. So if you have a small for gestational age infant who is small weight, small length, and head growth are low, this is called a symmetrical IUGR. And so that usually means that this baby has had both early and prolonged intrauterine nutrient deficits, and it's more detrimental to later growth and development. So if you have a baby that just might be small, but everything else is growing normal, they could just be small and maybe experience like a little bit of IUGR, and that's an easy catch-up growth. I shouldn't say easy, everybody's a little different, but it's a little bit easier to track. Whereas somebody who has shown like now stunting, almost early stunting, and their head growth, meaning their brain development may be smaller, may have a much more difficult time trying to catch up and may have, there might be a higher risk for later on growth and development issues. So these are all terms and things that we would take a look at like right when the baby is born. All right, so let's talk about nutrition for the healthy infant. So again, this is my cute guy. Or I'm going to show you lots of pictures of him like back in the day, aka last year. All right, so growth and development. What is going on physiologically? So there's a lot of things going on, and so the majority of this talk is really focused on the first year of life because that's where a lot of the growth and development is so rapid, and so many things are changing, and where a lot of the nutrition comes into play. Okay, so growth after birth weight is very rapid, and then will start to slowly decelerate. Your weight is usually doubles by 4 to 6 months. Usually by 6 months, you should have hopefully doubled your birth weight. Okay, and by 1 year of age, it should have tripled. Okay, so that's what the doctors are looking for. Length usually increases 50% from birth length during the first year, and then by 4 years old, it has doubled. So you're kiddos are now like double what they were at birth. Fat mass increases very rapidly during the first 9 months of life, and then will slowly start to taper throughout childhood. And your total body water, when a baby is born, they are primarily water, but over that first year, you'll start to decrease body composite or body water wise as your body composition changes to more fat mass. So you get more of a decrease in extracellular water. Stomach capacity. So when babies are born, they can only tolerate 10 to 20 mils at a time. That's how big their little tummies are. And then they'll move up to about 200 mils at 1 year. So we put this into perspective of how much that is. So 8 ounces is 240 mils-ish. 4 ounces is 120 mils. So 1 ounce, 2 ounces is 60 mils. So 1 ounce is 30 mils. So babies, when first born, can't quite tolerate an ounce of breast milk or formula. So you got to think that's why they are feeding so often, is because you need to get a lot of nutrition into them and they can only tolerate such a small volume. And that's actually like what the challenge for peds is they actually need quite a lot and they can only take in so much at one time. Okay? Gastric acidity decreases after the first few weeks of life, and this remains low then for the first few months of life. And this is an issue because it can increase the risk of microbial colonization or infection, and that's why breast milk is so helpful with those anti-infective factors, because it helps with, combating this overall decrease in gastric acidity and increase in risk of infection if not taken care of.
When you do enteral nutrition with the infant, do you use the mother's formula?
You try to. So if we have a baby that comes into the NICU, and let's say that the mom's milk does come in, we will have her pump and we will provide her milk via enteral feeds first. Same way that, let's say a baby or like an infant came in who was 6 months old and needed to be on feeds. If the mother is breastfeeding, we have her pump and we provide her milk first. We don't just give formula. We try to continue to support her breastfeeding. That's a good question. Because we also still want to provide all those health benefits as well. For their kidney function, the filtration rate is lower during the first 9 months of life. So they're not filtering out as much. However, at 6 weeks, they actually can concentrate their urine at adult level. So they can actually get their urine together. Just the filtering of everything takes a little bit longer. So let's look at our macronutrient absorption and digestive enzymes. So carbohydrates, our digestive enzymes that are in place are maltase, isomaltase, and sucrase, and they actually reach adult levels by 28 to 32 weeks of gestation. So before, if you have a baby that's at term, already at this point in life, they should have reached their adult levels of the digestive enzymes for carbohydrates. Lactase approaches adult levels at birth, and pancreatic amylase will remain low until about 6 months, and then it'll increase back up again. Right? So again, starting to think about what breast milk or formula that we're providing to babies, knowing that most of them can be tolerated, at least from a carbohydrate perspective. If you have a baby that's preterm and you have a primarily cow's milk formula that you're giving, they may not necessarily be able to tolerate it because they don't have lactase. All right, protein. So pepsin secretion from the stomach is fairly low from 0 to 3 months. Trypsin and enterokinase in duodenal fluid is also reduced. However, if you have somebody that is breastfeeding, the concentrations that are available can easily digest the proteins in human milk. And again, that's why the benefits of human milk of being in those particular forms and having more of the whey to casein ratios, because it does support or reflect already what's going on physiologically in the infant, which is pretty awesome. Development is so cool. Everybody wants to go into it. Fat from human milk and infant formulas are very well absorbed versus butter fat, so the form that's provided in either is okay. Human milk does contain 2 lipases. One plays a role in lipid formation, and that's found in the lipid fraction of milk, and that's the lingual lipase. And then the second lipase, or the gastric lipase, is what hydrolyzes triglycerides into free fatty acids and glycerol. So, sorry, this is the bile-stimulated lipase. So, sorry, lingual and gastric lipases hydrolyze the short and medium chain fatty acids in the stomach. And then gastric lipase also hydrolyzes long chain fatty acids, and important for initiation and digestion of the triglycerides. you guys need to memorize what lipases are there, but they play these two specific roles. All right, so what do babies then need? So in terms of energy requirements, 30 to 60% of energy intake should be coming from carbohydrates, 40% of energy from human milk, and 40 to 50% of formulas. That's what's provided usually as lactose. Okay. Recommendations are based on the composition of milk. All nutrient recommendations for infants are based on the composition of milk, of what is in breast milk, because that's supposed to be our gold standard of what to provide. Okay. Honey and corn syrup, you should avoid during the first year of life, completely eliminated, because there's a high risk for C. botulinum with consuming them. Okay. So usually wait till after a year until they can actually develop enough immunity to resist the spore development. That's why we say no honey. And I will let you know that for anyone taking the RD exam, this is always a question. Always out of the following foods, what should be avoided the first year of life? And there's always honey. I don't know why, it's just a very big thing on the RD exam. All right, so protein has a role in tissue replacement and growth. So growth is the big key here. Requirements per kilogram of body weight are much higher than older children as well as adults. So whereas adults, we are RDA, DRI, 0.8 kilograms per 0.8 grams per kilogram of body weight. For kids, the first 6 months of life can be up to greater than 2 grams per kilogram of body weight, and you're like, holy cow, that's a big difference. But remember, babies are born around how many kilos? 5. No, that's a big baby. Anywhere between 3 and 4 kilos, right? So that's not, when you do the math out, it's not. I mean, we still need a bunch more, but per kilogram of body weight to support that growth and tissue replacement is much bigger. Infants require a higher percentage of essential amino acids than adults do. So 40% of their protein should be coming from essential amino acids versus approximately 19% that we need for adults. Human milk easily meets protein requirement during the first 6 months. The second 6 months, the diet should be supplemented with protein-rich foods like yogurt, strained meats, and such. The risk of low protein in an otherwise healthy infant is only really an issue if they aren't getting those foods, and if a baby is formula fed and it's diluted, or you're providing only water, you're not providing if you wanted to do another dairy or non-dairy source like milk that had protein in it. For your lipids, again, your essential fatty acids are going to have a very key role in visual and neurologic development. The current recommendation is greater than or equal to 30 grams of total fat per day, and again, based on milk composition, breast milk. Lower fat formulas or diluted formulas just overall support lower energy intake, so you have to be careful of those. Human milk contains essential fatty acids and their derivatives, and so for 0 to 6 months, that should be about 4.4 grams per day of your linoleic acid, and 4.6 grams per day from 7 to 12 months. For your linolenic acid, you're looking to get about 0.5 grams per day during the first year of life. Again, just to kind of reflect what we talked about for our lactation section of the lecture today, your fatty acid composition of breast milk is really going to vary based on the mother's diet. So this is why it's important to make sure that you're getting those, omega-3 rich fish sources or other sources like, walnuts and eggs, omega-3s and such like that. So water requirements. Requirements are really determined from skin, lungs, waist, and growth losses. For babies that are up to 6 months old, the DRI is 0.7 liters per day. It's about 700 mils. So that's hopefully easily met through just regular breastfeeding. 0.8 liters per day at 7 to 12 months, and really just a factor of the fact that your baby has grown, and so they have more body surface area. Babies are much more vulnerable of developing fluid and electrolyte imbalances because they are smaller, and so when they lose a lot of fluid, it's very much reflected. So during hot weather, or if they're experiencing diarrhea or vomiting, so during hot weather, if you see that a baby is profusely sweating, and this is hard because a lot of times when you bring babies out, especially if it's sunny, you don't want their face and their skin exposed to the harsh sun rays, so you bundle them up as much as you can, and then you're like, oh my god, I'm now like causing them to sweat and lose fluid. So it is a balancing. Or yeah, if they're experiencing diarrhea and vomiting, we do have quite a few children that do come into children's because of dehydration if they are really sick and they get a bug where they have a lot of diarrhea and losses. So they have to come in and be rehydrated and a lot of times get some electrolytes to kind of reestablish that balance. Where you can have an issue with the electrolytes is if you have too much sodium, so during dehydration. This can occur with even just a greater than 10% loss of body weight. This may have neurological effects on the child, meaning they can be displaying neurological issues. You have hyponatremia or not enough, so fluid overload that can occur when, let's say, you have a formula that's excessively diluted, or use of bottled water versus electrolyte beverage to treat diarrhea or vomiting. So they want to replace with the losses, but they don't give enough electrolyte, they just give the fluid, so it's actually causing more of a loss. These babies can experience restlessness, nausea, more vomiting, more diarrhea, excess urination to try to get that extra fluid off, as well as seizures. Okay, so when babies are having fluid imbalances, it's really important to make sure that you provide treatment right away because they can experience some pretty not so fun effects. Some highlighted micronutrients. So for iron, so iron's a big one. For full-term infants, for full-term infants, especially if the umbilical cord had delayed clamping, meaning the doctors wait to actually clamp the cord for a bit, they're considered to have adequate iron stores for 2 to 4 months. Breastfed infants at 4 to 6 months could be considered at risk of depleting their reserves, and so they may need an additional supplement. Iron in human milk is highly bioavailable, but there's not that much of it. So that's why you have to be careful of iron deficiency and iron deficiency anemia in older infants. So in some practices, there is recommendation to just routinely supplement with iron, but often what happens is between 4 and 6 months, or around 6 months, you start introducing solid foods, and one of the first solid foods that you introduce is iron fortified cereals, and so that's why you don't necessarily need to supplement, provide a supplement. You just need to make sure that you are supplementing the infant's diet with an iron source, like iron fortified cereals. And why this is a big deal is that iron deficiency, especially in developing children, can cause long-term cognitive issues. Okay, so early on, you want to make sure that you provide enough. It can impair motor development as well as cause some behavioral issues later on in life. All right. This handsome guy right here. That was we took him up to Redwood National Park, and it was quite warm for whatever reason, so we got to hang out instead. Okay, so other micronutrients, zinc. So newborns, infants are pretty much dependent on dietary sources. They don't have enough. It is much better absorbed from human milk versus formula. Oh, sorry, I wanted to mention one thing. Infant formula-fed infants don't typically have iron deficiency issues because all infant formulas have iron fortified. They're all iron fortified. Or I should say, most all of them are iron fortified. The standard ones are all iron fortified. So that's why I didn't bring that up here. Anyways, but for zinc, it's better absorbed from the human milk versus formula. And you can also, when you start to introduce more of the foods, solid foods after 6 months or around 4 to 6 months, it can help with your zinc supply. Fluoride is helpful in preventing dental caries. Human milk is a pretty poor source. However, you really don't necessarily need your fluoride until teeth come through. And so usually if you are in a community where the water is fluoridated, if you're mixing your fluoride that way, or mixing your formula with tap water, or if you are starting to introduce water after around 6 months of age, your infant is probably getting enough fluoride through that. Vitamin D, as we mentioned before, human milk is not an adequate source, therefore you do need to be supplemented. The American Academy of Pediatrics recommends that all breastfed infants need at least 400 IUs per day. Formula infants who consume less than a liter or 1,000 mils per day would also need this, but most formulas now are just come standard fortified. Okay.
the recommendation for vitamin D actually used to be to put kids out in the sun for like 30 minutes per day. They had to be like completely naked, but unfortunately, that's not great because skin sensitivity, as well as skin cancer, we want to not start that process early. So now it's just regular supplementation. B12 may be of concern, similar during pregnancy if you have a mom who is vegan or very strict vegetarian where they're not getting or they're getting very little animal products, and so milk or would be vitamin B12 deficient, and so you want to make sure that the mother is getting some sort of a supplement so that her breast milk content is also influenced. And this is something that we also talked about last week, that again, we should be thinking about this preventatively, so maybe before pregnancy, working with these women. Vitamin K needs definitely special attention. Deficiency can cause bleeding or hemorrhagic disease. Human milk contains less vitamin K than formula, and it's especially low during the first week of life, and that's why the majority of states, definitely in California, actually requires a vitamin K injection at birth. So usually once you give birth, poor baby has to get heel prick, a newborn screening, hearing test, and then they also get a vitamin K injection as well to kind of help out. And because it's only one injection, it is a fat soluble vitamin, so it hangs around a little bit longer. So again, the recommendation is to exclusively breastfeed for the first 6 months of life, and then breastfeed in addition to introducing complementary foods up to 12 months. And being able to hit up 6 months is really hard, especially if you have a child who is, developing quite quickly and like actually is taking an active interest in eating. If you introduce foods before 6 months, that's fine. It's all very individual. The goal is to try to do 6 months of exclusive breastfeeding, but again, everybody's very different. Okay. A little bit about formula feeding. So to ensure adequacy of infants' diet, there's actually, the FDA actually heavily regulates formula. They passed the Infant Formula Act that actually requires that all infant formula manufacturers follow specific nutrient recommendations so that we know and can ensure that all infant formulas that are being provided to children are meeting nutrient needs. Most of the infant formulas, again, just as a reminder, are made from a modified cow's milk, and they add in carbohydrates, vitamins, and minerals in an easily digestible and absorbable form. Okay. Arachidonic acid and DHA are being added to some formulas, not all formulas. Some formulas also now are including pro or prebiotics, so sometimes you see like such and such with prebiotics or with prebio. Similar to our enteral formulas, there are a lot of infant formulas out there, and we're not even going to get into it in this class, but if you ever go into Peds, I feel like some of the challenges is just knowing all the infant formulas, because in addition to just the different types of infant formulas, there are different brands, and some brands are similar, some brands are different, and so sometimes you might have patients that get admitted and they're like, we're on this formula, and then your hospital might not carry that formula, so you need to be able to like provide the like comparable one. So anyways, there's just a lot of formulas. There are also soy-based formulas, but they have gone under quite a bit of scrutiny. One, there's still a lot of questions about whether or not providing very high phytoestrogen content coming from isoflavone, which is the chemical structure of soy, what that does in terms of early development. And also soy, as we'll talk about in our high-risk Peds lecture, is an allergen, and those individuals who are allergic to cow's milk actually have a pretty high likelihood of being allergic to soy as well. So it's not a great alternative if you have a baby that has a milk protein allergy. This is something that we actually do a lot of education to our residents over, because a lot of times when people think like, oh, well, if we don't do regular milk, we'll just do soy milk. And it's like, no, we can't do that. Actually, that you could be just, they could be allergic to that as well. So usually we try to avoid soy-based formulas as much as possible. But there are some kids that only tolerate those, and so that's what we'll provide. Casein hydrolysate formulas are also available, especially for infants with really high allergies to both lactose or soy as well. These are called Neocate, or in our hospital it's Neocate. You have Neocate infant and Neocate junior. Okay, so let's talk about some feeding pattern development, because this is a lot of times where we see the most amount of like kind of nutrition intervention, and this is both from like an infant feeding, from breastfeeding and formula feeding, and then as we start to move towards introducing solid foods. So immediately a mother should be encouraged to nurse her infant very soon after birth, so skin to skin, and also initiating breastfeeding. It is quite cool and also like kind of like eerie to know that infants kind of really already know what to do. Like they know that they need to actually latch on and suckle, to be able to initiate breastfeeding. They're like, that's really cool. Regardless of whether infants are breastfed or formula fed, they should be held and cuddled and during feedings to kind of initiate that sense of security and warmth. And also that's going to really help with the mom being able to, mom or dad, because or caregiver, whoever is feeding the child, to be able to know when that child is actually hungry or full is the other thing too, is being able to know when they're actually full. Once a feeding rhythm has been established, and that can take a short amount of time, that can take a long amount of time. Every infant is very different. Infants, you will notice, will become fussy or cry to indicate hunger, and they normally have a specific cry. And then when they are full, normally they kind of smile, or they just get a little what we call milk drunk, and they like kind of just like settle back in, smile, and then like fall asleep. Or if they're smiling, that just means they're having a lot of gas. Either one. Infants, this is very key. Infants need to be the ones that's establishing the feeding schedule, not adults. Sometimes it's very difficult, especially if you have adults that are very scheduled and they're like, oh, every 2 to 3 hours I need to introduce something to my baby to eat. And really, in the beginning, it's very hard to let go of that, saying that I'm slightly OCD myself. But Adam had to be the one to let me know that he was hungry. And if he, especially in the beginning when he cried, I'm like, oh, you must be hungry. I tried to feed him, and he was like, nah. And I'm like, okay, you're not really hungry. So it does take some time, but they really are very good at letting you know that you're hungry or not hungry. Initially, most infants feed every 2 to 3 hours, and that's very true. Because again, remember, they can't even tolerate an ounce of breast milk or formula, so they do need to eat more. With that being said, let's say that you have an infant that's pretty sleepy and that they are feeding, like, let's say more 3 to 4 hours at first. Maybe they are feeding very well on both sides and then are only eating or are sleeping that much. They may be fine. It's just usually every 2 to 3 hours. By 4 weeks, they're usually every 4 hours, and they go through this nice period where they like get up, they feed, you burp them, they go back to sleep for like 3 hours, and they wake up, they feed, you burp them, and they go back to sleep for 3 hours, and you're like, oh, this is amazing, and then they like wake up a lot more, and then they don't ever want to sleep. Yes.
Have there been any studies on like how often an infant's being fed and their outcomes, like in terms of obesity or malnourishment?
Yeah, no, definitely. So they have taken a look. There's been a lot of like studies looking at how often. There's a lot of like factors that go into that. How often and how long babies are fed. It's hard because you can get like dietary recall data on that, but if there's no like if you can't like say like when we see like what's in your milk, like you have to also have moms like who are breastfeeding like provide samples of milk to find out like, oh, nutrient intake wise. But in terms of like just feeding patterns, yes. Those that are fed, taking a look at those that are fed like more commonly, like when they're younger, 2 to 3 hours, and then move on out, and then are able to select foods and such, like when they get old enough to be able to eat foods, show better outcomes in terms of like growth patterns and decrease obesity. But those that don't, and also those that are, that's not so much that if those that are formula fed have higher rates of obesity, but they have a different growth pattern trajectory. So there are studies that kind of show like if you're formula fed and you're fed this much, or if you're breastfed, you're fed this much, even though maybe, at 2 years their weight is about and length is about the same, you might see rapid growth from breastfed infants at first, and you're like, oh, we're feeding them too much, and then it levels out. Whereas like for formula fed, you see that their growth pattern is a little bit more steady, but then it like increases later on. So there are lots of studies like that, but there's also studies that are just observation, and there's studies where they're trying to take biological samples as well to actually take a look at like some different cognitive or behavioral outcomes. And those are not fully finessed out yet, just because we don't have enough like participants in those studies. But yes, there are studies taking a look at feeding pattern development. Good question. Okay, so at birth, already infants can coordinate sucking, breathing, swallowing, and prepare to actually suckle liquids. This is why they are like ready to go in terms of breastfeeding. Again, that does not mean that they know exactly what to do in terms of like once they get latched on. The latch is sometimes really difficult. And so that's where, again, as a dietitian as well as lactation support can really help with making that transition. During the first year of life, thinking about some other basic developmental things. So infants develop their ability to grasp, okay? So we have the fine motor and gross motor skills that are also developing at the same time. So the first grasping action is the palmar, or like the full hand motion, and then you get the pincer grasp, right? So again, thinking about the types of foods or things that you're gonna introduce. That's why like infants at the beginning, yeah, they're like most of the time like this, they're kind of floppy. They're not gonna hold a bottle, okay? But like when they get older and you introduce like a cup and they can hold it like this, that's when you would introduce it. If you have smaller food items and they can start to use their pincer grasp or their fine motor skills. So thinking about that in terms of when you're introducing in foods. They develop more mature sucking, rotary chewing abilities and become able to use their fingers to feed themselves as they get older as well. Okay. So this is why it makes sense that primarily liquids are going on for the first 6 months of life and then introducing in more solid foods. So between 4 and 6 months is when mature sucking is refined, munching and chewing movements start to begin. So this is when you might start to see the introduction of strained foods, like your infant cereals. And I put in there between 4 and 6 months because that's usually an average, even though the recommendation is exclusive breastfeeding until 6 months. 4 to 6 months is usually the average to which people introduce foods. What you introduce is not necessarily important. The importance really is that you do one food at a time and you wait a day or so really to see if the infant or baby can tolerate it, as well as if that baby is allergic to it. Sometimes they say introducing vegetables before fruits may increase acceptance. I've seen this in both places. Sometimes it does, sometimes it doesn't. Breastfed infants typically accept greater quantities than do formula-fed infants and have a little bit wider palate, and that is mainly because if a mom is introducing different types of food, there's a little bit of research to show that the taste perception and taste sensitivities are influenced in the baby. As oral motor maturation proceeds and infants' rotary chewing abilities develops, you can then get more textured foods and you can introduce them. Weaning from breast to bottle to cup, usually you proceed very gradually based on your infant's rate of growth as well as their own developmental skills. Usually you start to introduce a cup around 6 to 9 months, especially when you're introducing more solid foods. And then after 1 year of age, usually you get them off the bottle. Okay. So around six months is when you you're more of like your time to introduce foods. The school of thought is that you should introduce your iron fortified cereal first and then do other single ingredient cereals. Usually rice cereal is what people choose more often than not. However, last year, if anybody follows any toxicology issues, anybody know what was going on with rice last year, not only for infants, but also for adults as well? Arsenic. Yes, arsenic issues. So they were finding more than detectable levels of arsenic in rice. And it didn't matter if it was, the regular rice cereal. Rice is, if anybody knows how rice is produced, you're in like water patties, and so like the arsenic from the groundwater was getting into the rice, and so there was a lot of question about whether or not infant cereals would be affected, and there are levels of arsenic in there. There isn't necessarily any levels or any studies showing that at this level there would have been detrimental effects in terms of development. However, they don't know because they didn't have any studies, and so a lot of focus was put in on eating other cereals like oatmeal cereal, which is what we did.
So relating to that, would breast milk be potentially affected as well?
If you were consuming a lot of extra rice, that's a good question. I don't actually know the answer to that. You would think that because you'd be getting a little extra arsenic. It's interesting the way, like, even though rice, like regular, like long grain brown rice had arsenic in it, the levels were actually lower, I think, in that rice versus like the infant rice cereals. So, but yeah, I mean, if you're consuming a toxic metal in excess, it is going to find its way into the breast milk. So it could have, if you were eating a lot of rice. That is it. I would have to go back and see like what epi studies they had going on looking at. I'm sure there's some out there. Good question. So anyway, so then usually you would mix the cereal with breast milk or formula to start to transition the taste of it. We did that quite a lot. Usually you don't put cereal in a bottle. You usually offer like a couple tablespoons at first, and then also water to drink. So we didn't introduce cereal first actually to Adam. We did avocado because we wanted to do something different, and I did a lot of reading about, do you have to do rice cereal? And I asked a lot of my friends, and honestly you don't. The biggest thing of why people do rice cereal is because it is iron fortified. So we just need to make sure that one of the next foods was a more iron fortified source, so that he got that as well. So you don't have to do cereal first. It just happens to be an easy one, and it's very well tolerated. Okay. And also remembering that at first they're not really going to start eating. It's really just like getting used to eating and like using your mouth in that way, and usually ends up all over the place. Usually around 6 to 8 months is when you start the strain fruits and vegetables after baby has tried all the different baby cereals or foods like avocado, mashed, what have you. And you offer again 1 to 2 tablespoons at a time. Sometimes you need to mix in with breast milk or formula, sometimes you don't. And you just continue to offer mashed or finely chopped fruits and cooked vegetables after trying all the strain fruits. So this is like in general, everybody has very different feelings about this. There's a big movement called baby-led leaning. I don't know if anybody's heard of that, where like you don't necessarily do baby foods, but you actually are just providing food from what like you would be eating as an adult, and like giving them small bits and having babies like select their preferences that way. Lenny and I kind of did a combination of like somewhat traditional, but also baby-led weaning, because we just wanted Adam to eat regular food, not necessarily do like just the traditional baby food track. Yes.
What did you give Adam after for the iron?
For the iron, we did oatmeal cereal, the iron fortified oatmeal cereal, and they had that at school as well, and they were really good to not. I think at school they also stopped using the iron or the rice cereal. They used just oatmeal cereal instead because of the issues with the arsenic. Yeah, so we did that and just would like mix it in with things once a day. All right, so this is Adam throughout the stages of eating. At 8 to 12 months, you can start more of the finger foods, encouraging self-feeding and allowing baby to get super messy. Super messy is key. Adam at home gets double bibbed. He gets a smock. This was like the best parent hack that someone told me. He gets a full smock, and then he gets the bib that has the cup at the bottom so that he can get the stuff that he has dropped in there. Honestly, there are a bunch of different textures. You just need to be aware about the fact that your child can choke. They're still trying to learn to feed themselves if things are still tough. Also, you have to think about, do they have teeth? Adam didn't get his first tooth till he was like 10 months. Takes after me, and like poor kid, now he's got 2 bottom teeth and like a full set of top teeth. I don't know how those other teeth are going. But so like for some of the foods he like loves to bite down on, but of course he only has like the 2 bottom teeth, so he's like. But anyways, and also they're encouraging the use of a cup. At school is great, and we mimicked a lot of what they were doing at school, because here on campus they provide both breakfast, lunch, and snack for the kids. And so at school his water cup is 2 handles, and his milk cup is no handle, so we do the same thing at home, so it's reflected the same. So this was Adam when he first started eating. This is a nice yogurt cereal mix, and he was just getting excited about using a spoon, and I think he wasn't actually like really feeding himself. I just happened to catch the picture when he like put it in his mouth. This was the spaghetti and vegetables, nice and cut up, and he was having a blast feeding himself at school for that. This was for his first birthday. We took him out to the egg shop in Montclair, and yes, he did devour a cut up Mickey Mouse pancake and cut up fruit. He loves it. He loves his food. Okay, I know we're reviewing the last few days. So some just items and considerations to think about. You do need to be thoughtful in how you're thinking about feeding your child. You do want to make sure that you are providing a balanced diet. So Lenny, this is Lenny, my husband, this is their feeding day. We sit down and meal plan for ourselves, and we think, okay, we want Adam to eat these foods too, so we just make sure that we have enough for him, so that even though he eats dinner closer to like 5:45, 6, which is sometimes a little early for us, that at least I can sit down, or he can sit down with him, depending on who's home with him, to be able to have somewhat of a dinner with him that's the same as ours. But there are a lot of foods available if you wanted to do quick and easy foods. There's a lot of ready to serve. There's a lot of strain, like junior fruits and vegetables. So if like prep time is something that's tough for you, you can purchase foods that are already prepped that way. If you wanted to make your own baby food, it's definitely also an option. There's some great like cookbooks out there. There's some great also appliances that can help you with making your own baby food. We did that as well. We had a combination of both. But yeah, so really like a lot of your foods you got to think about is that you want some simple, uncomplicated foods. Mild flavor at first, and then increase, your flavorness and your spiciness, and also providing a bunch of different textures as well. Okay. Serving sizes, they're going to be eating small amounts, which is smaller amounts than adults, but it's not that much smaller. Don't force feed. That's a big one, especially because one day your child will eat everything you serve to them, and the next day you might serve the exact same meal and they throw it all over the ground, and you're like, what the heck, you loved this yesterday. Then a week later they love it again or they still hate it. So it's hard to like be like, what? Like, but you really can't force feed, and you just want to continue to be positive, and that really has shown to help out. All right, so let's talk about some weight gain, and then we'll talk about some basic peds stuff. Weight gain, generally when caregivers are sensitive to infants' needs and satiety cues, full-term infants adjust very naturally. They let you know how much they need, how much they don't need. It's pretty awesome. If infants do have a decrease in their rate of weight gain, they don't gain appropriate weight, or they don't grow in length appropriately, and this would be tracked on through their pediatric visits, which we'll talk about in a few slides, then we do need to take a look at how much they are eating and what they're eating to make sure that, that we are preventing potential malnutrition, or also being, keyed into, is there an undetected disease that's going on that we want to make sure that we capture, which unfortunately can happen. All right, so let's quickly talk about the healthy child. All right, so this is Adam now. Here's his first birthday. This was him last week at school, so he's now not so baby anymore, which is sad. Okay, so how do we evaluate growth? We use growth curves. So you're next week gonna be using growth curves to work up a child. Okay, it's based on data from comprehensive health surveys, healthy, racially diverse breast and bottle-fed infants. We have two sets, WHO and CDC. So we have one set that we use from birth to 24 months of life, and then one from 2 to 20 years. We have so two sets for males and two sets for females, because male and females grow differently. All right, so when actually using the growth curve, we all probably have one from our days of growing up. It includes looking at your weight for age, your height for age, your weight for length, your BMI as you get older, your head circumference, and then you're tracking along as you get older. So cutoffs to remember when you are tracking children. Anything under, for weight particularly, we're talking about weight, anything less than or equal to the 5th percentile is considered underweight for a child. Greater than 95% or equal to 95% is considered obese. Between 85 to 95% is considered overweight. So the key thing with growth charts we'll talk about in just a couple minutes is not just looking at one point in time, but you're tracking over time the growth pattern. So this is what little girls would look like. I shouldn't say little girls, it goes 2 from 20. So girls would look like for height for age and weight for age. This is their growth trajectories. This is the 2 through 20, the CDC ones. This is the CDC one for boys, so slightly different growth pattern. Okay. So again, the key thing you're going to think about here is not so much like if you have let's say you have somebody that plots down here when they're 7 years, and then they continue to plot down here, but they follow the same growth curve on that same line. That is considered normal. So even though they may plot lower, they just might be a smaller person. So it's important to track that over time versus just looking at one point in time to be like, oh my gosh, you're lower. But if you do have a patient that, let's say, was tracking at 50 percentile and then all of a sudden starts to drop below, that's when we'd be worried. If you have someone that starts to track above, that's when you'd be worried. All right? So how do we gather these things for anthropometrics? Well, we need to take a look at weight. So we would do a baby scale for our infants, or we would do a regular scale for if they're older. We do head circumference. For length for the babies, you usually do a length board where you stretch them out and you have their feet lie flat, and then you see where they stretch out to, because babies, since they're used to being in the womb, are naturally contracted until they get used to being able to get their feet out. And then for kids, you would do the stadiometer where they would stand up tall. Okay. You should be doing heights and weights every time they're at the doctor's, every time that they're at the, in the hospital. You would evaluate the diet next for kids, and this is where you're going to start to, identify if there's any issues. Items that you're going to be focusing on are the quantity and quality of food that they're consuming, any parent-child feeding relationships, so positive as well as negative, or even caregiver-child feeding relationship. What's the environment at home? What are their meal patterns? Kids, because of the amount of growth that they have going on, need to actually eat a little bit more often. So are they eating just 3 meals a day, that's it? Are they eating 3 meals, 2 snacks? Like what is the, when are they eating them? Where are they eating them? Any psychosocial factors that may impact food selection, as well as any clinical and physical factors. Are they on certain medications that they have to avoid foods? Are they eating more foods because they're on other medications? So thinking about those things. So the next series of slides really just kind of goes through the different nutrient requirements. So I don't necessarily need to talk about these in great detail. There's different ways, similar to adults, how we assess energy needs. I posted a resource sheet on your handouts and resources that kind of combines all the PEDS ones onto one place. But basically you have different tables and equations that can be used. A few things I just wanted to point out really quick is that we have a few different ways of estimating energy needs. The most common ways that are used are the RDA for age and the DRI for age are for very normal term infants and kids. Kind of highly, I find highly overestimates needs, but it is good for a good general healthy indicator. So DRI for age is what we use at children than what most places use. I have seen that the RDA is used for quick and dirty methods. But basically, as you get older, you have more specific equations and where you're taking into consideration their physical activity level, okay? If you have a child that has any stress factors, so this is for when you have children that possibly are sick or infection or going under treatment for something, using something like the WHO or the Schofield equations, which kind of have about the same range of calorie calculations you would use, because then you can add in these additional factors. So similar to Mifflin St. Jeor. Okay. Here's your protein needs for age, broken up that they need more per kilogram of body weight earlier on because of that rapid growth, and then it kind of drops off. It's still a little bit higher. And then also then your micronutrients of concern. So really here we're just going to focus on iron, calcium, and vitamin D to make sure that they're getting enough. All right. So yeah, so it's 10 o'clock. Oh, I forgot one last one. This is how you calculate fluids. You can't do 1 mil per cal for this population. You have to do it by body weight, but it's not too bad. So that's it. It's 10 o'clock. So we made it through. Yay. I've had a few of you email me for questions to meet for office hours, especially if you're taking microbiology and you can't make my morning office hour. I'm sorry.